My name's Julian Eaton. I'm a psychiatrist by background, but have been working in development for about 15 years now, particularly in sub-Saharan Africa. I work for London School of Hygiene, Tropical Medicine, and CBM International. Historically, we've really thought about mental health in quite a narrow way in relation to a kind of disease model where ill people needed to be made better so they could fit back into their previous social roles. But we're increasingly realizing that actually there are wider social determinants that feed into the way that someone is able to fit into society and the likelihood that they will develop what we call a mental health problem. There are many different factors, but probably the most profound is in relation to poverty. And the relationship between poverty and mental ill health has now been very well evidenced. And excitingly for people who are working in development is that that also gives us some clues as to what we might do about it. So we know, for example, that mental ill health tends to drive individuals, their families, and their wider communities into poverty. So if we think about making better mental health care available, that's a good way of thinking of leading towards reduced poverty. And there's very strong evidence now at a global level of the huge impact of mental ill health on economic development, and that's something that is being taken very seriously, for example, by the private sector and business. On the other hand, we know that extreme poverty, for a number of reasons, leads people into mental ill health. They're not able to get the care they need. It's very stressful having to worry every day about whether you eat or not, or whether your children can go to school. So there are significantly increased rates of mental ill health among the very poor. One of the ways that we can think about improving mental ill health is interventions in relation to poverty of individuals and families. And there is now increasing evidence that if we are able to increase a family's income, that is likely to lead to better mental health outcomes. One of the specific ways that we've started to measure at a very large programmatic level is cash transfers. And cash transfers have been shown to improve not only some of the physical outcomes like weight and nutrition of children, but increasingly the mental well-being of the people who are able to access cash transfer as opposed to those people who don't. One of the clearest examples of where health is not necessarily the most likely factor to make a difference is in relation to suicide. We know now that suicide is the second biggest cause of death among people under 29 around the world, which is an incredible statistic, and in many countries it's the single biggest. There are a variety of reasons for this, but we know that most of those are social. They're related to poverty, they're related to too much stress at school or university, they're related to people having experiences of violence at home, for example. So those are the sectors where we need to think about making a big impact on an issue that you might otherwise think is mainly a mental health issue. Of course, mental health is important. People having access to mental health care and someone who will ask them if they're feeling suicidal, if they have depression, is important, and it will reduce to a certain extent suicide. But at a population level, if you're going to really have an impact, you need to think about the social drivers of suicide, not just think of it as a mental health issue.